Hello everyone, this is Professor Flourish. Today we're going to be talking about the respiratory system. Now, with the respiratory system, I do want to go over some topics that you probably covered in anatomy and physiology. It's just a reminder of those topics as we look at it through a nursing lens. So your respiratory system has two primary functions, which is supplying oxygen as well as removing the carbon dioxide. Now with this, it caused that homeostasis mechanism that we talked about in our acid-base lecture. And with it, we also have this what's called respiratory mucosa, which warms, humidifies, and filters all the air that we breathe in. Before we dive into the mucociliary apparatus, I do want to kind of explain one thing about normal flora. Because the mouth, the nose, and the throat are all exposed to the outside environment, they're basically already colonized by bacteria that's considered our normal flora. These organisms will not cause illnesses in healthy persons. In fact, they actually help us from getting really sick because they're the good bacteria that we need. Now, on the other hand, the lower respiratory tract, the alveoli do not have normal flora. So we don't want to see any bacteria in those lower respiratory tracts. The mucociliary apparatus, basically what happens here is you'll have inhaled particles such as dust, pollen, and pathogens that are trapped by the mucus and removed from the airway passages. So what you'll have are these things called these goblet cells that secrete mucus, and I'll show you on the next slide what that looks like. Basically, the upward motion of the ciliae moves the mucus from the bronchioles up through the throat where it's swallowed. So these like little things that look like little fibers, they basically push out that mucus and then it goes up into your throat and you can either swallow it or cough it out. Now, the reason that we tell people not to smoke is because smoking actually paralyzes the mucociliary apparatus. So these inhaled particles stimulate smokers to forcibly cough to mobilize mucus. Failure to remove excessive particles from the respiratory system increases the risk of infection. Because if you remember what I said, that lower respiratory tract and the alveoli do not have normal flora. So what happens with them is the system that's supposed to help us push out all those bad bacteria or even some of our good bacteria aren't working because they're all paralyzed. That mucociliary apparatus is paralyzed. So that in a nutshell is why we tell people you really shouldn't smoke. And here's where I was talking about where you'll have the goblet cells that are releasing the mucosa or mucus that can push out those dust particles that can push out that stuff that we don't want. So these are basically the organs of the respiratory tract, and we split it into the upper versus the lower respiratory tract. In the upper, you have your nose, your pharynx, your larynx, and in the lower, we've got our trachea, our bronchial tree, and then our two lungs. So the first one we're going to talk about is the upper respiratory tract, and this is just the basic anatomy and physiology behind it. So like I said before, this is our nose, our pharynx, and our larynx. And I like this picture because it kind of gives you a separation between the upper respiratory tract versus the lower respiratory tract. And as you can see here, we've got our nasal cavity and then our pharynx that can be further divided into our nasopharynx, our oropharynx, and our laryngopharynx. And then you've got your larynx here, and then it starts heading into the lower tract with the trachea and the left and right primary bronchi. But up through here is most of our upper respiratory tract. And as you can see, that's where those areas that are more exposed to that normal flora. So the structure of the nose is this nasal septum that separates the interior of the nose into two cavities. You've got mucous membrane that lines the nose, and once again, it's designed with a purpose. Even those little hair fibers are designed with a purpose to help you push out things. Like when bacteria does come, it can help us push out that bacteria from our nose. You do have different sinuses, which on the next slide, I believe, shows a picture of these sinuses. And when somebody will have an infection that's like an upper respiratory infection, a lot of times these can come swollen and you can actually touch them and feel where that sinus infection is located. Nasal polyps, not everybody has these, but I just kind of wanted to talk about them. They're basically these non-cancerous growths that project from the nasal mucosa, and they're usually associated with things like chronic hay fever. And here you can see a picture where we've got the split between the two sides of the nose, and then you can also see the different sinuses. And if you've ever gone to your primary care physician, a lot of times when you go in there with something like, I have a fever, I've been sneezing a lot, one of the first things they do assessment-wise is touch around your face. They're trying to feel the sinus area to see if it's inflamed or not, or feel if it's puffier than usual. One of the functions of the nose is that it warms and moistens the air. This is why if you've got somebody who's on chronic oxygen, a lot of times we'll go ahead and humidify it because you want a little bit of moisture that goes in when they're breathing inwards. It also contains sense organs of smell. So on this slide, I've got two different anatomical disorders that are relevant to the nose. The first one is a deviated septum. So when we talk about a deviated septum, what we're really talking about is a septum that is abnormally far from the mid-sagittal plane. What this basically means is that we're supposed to have these two parts of our nose split in a very direct way, but sometimes what can happen, and this can be caused by congenital issues or acquired issues, it's very far from where it should be. Now, the reason that this matters is because when you're putting in an NG tube, you always want to ask your patient if they're able to talk to you, if they have a deviated septum, because then you can go in there with a little bit more purpose when you're actually putting the NG tube in. The other thing you can have is this thing called epistaxis, which is basically a bloody nose. Now, this can result from mechanical injuries to the nose, hypertension, or other factors. We'll talk about this more in MedSearch 2, but that's just, if you ever see the word epistaxis, that's what that means. So the pharynx, the structure of the pharynx is basically the throat. It's 12.5 centimeters long, and it's divided into the nasal pharynx, the oropharynx, and the larynopharynx. It's got two nasal cavities, the mouth, the esophagus, and the larynx, and auditory tubes all have openings in the pharynx. So it's almost like the gateway for all these other anatomical parts of our body. The pharyngeal tonsils, an opening of the auditorial tubes, open into the nasal pharynx. Other tonsils are found in the oropharynx. And once again, we've got those mucous membranes that line the pharynx. The main functions of this is a passageway for foods and liquids, air distribution, so passageway for air, and tonsils, which are tonsils are these masses of lymph node tissues that are embedded in the pharynx that provide immune protection. So like I said, your pharynx is basically just your throat, and what happens with it is it has these different openings that can allow the air distribution as well as the home of your tonsils. This is just another picture here. As you can see, there's the larynx. It's got different holes here, and then you can see where it's pointing out like the vocal cords, and then there's the different tonsils. It kind of gives you a better view of everything respiratory wise. The larynx is located just below the pharynx, and it's referred to as the voice box. Once again, we've got mucus lining, vocal cords stretch across the interior of the larynx, and its main function is air distribution again, as well as voice production. So if somebody's got cancer to their larynx, then it can cause them to not be able to speak because they'll a lot of times just remove that voice box. So when you're thinking about voice box, that's where your larynx comes in. And then here's another picture here. It shows like deeper down the trachea, the vocal cords through the side here. Now we're going to get into the lower respiratory system. The lower respiratory system consists of the trachea, the bronchial tree, and the lungs. The trachea, it's basically a tube called the windpipe is what a lot of people refer to it as. It's about 11 centimeters long and it extends from the larynx into the thoracic cavity. So now we're moving into the thoracic cavity. It's once again has that mucus lining. It has C-shaped rings of cartilage to hold the trachea open. And its main function is that passageway of air to move to and from the lungs. So I added this picture here because what I want you guys to kind of understand is how close the esophageal sphincter is to the trachea. So the upper esophageal sphincter is what basically opens, like every time you swallow, it's this little flap here that opens and lets your food go all the way down your esophagus towards your stomach. Now with this little flap with older adults a lot of times can start weakening, and instead of the food going down through the esophagus, and you'll learn more about this when you get into GI, but instead of the food going down into the esophagus, it instead goes down the trachea and lands in their lungs. Now, with this can cause immediate aspiration, which we'll talk about in the next couple slides, or this can cause silent aspiration. When it's silent aspiration, what happens is the food ends up going down into the lungs. Patient doesn't really know, but like I said before, you don't want any sort of bacteria, pathogen, food, anything inside your lungs. So that food ends up molding and the patient can become very, very sick. They develop pneumonia. So that's why it's very important that we assess our patients to make sure, can they swallow? Is the food going down the right path? And that's why I kind of tell you guys to understand, like, with your trachea is different. When things go down the trachea, it's going into the lungs opposed to going down the esophagus. So this is where I was talking about obstruction of the trachea. Blockage of the trachea occludes the airway. So if this is an airway problem, that's the A of our ABCs. And if complete, it causes death within minutes. Honestly, you start losing brain cell activity after 5 minutes of not having oxygen go to your brain. Tracheal obstructions cause more than 4,000 deaths annually in the United States. Abdominal thrust maneuver is a life-saving technique used to free the trachea of obstructions, and it's also called abdominal thrusts. A tracheostomy, which we'll talk about later, is a surgical procedure in which a tube is inserted into an incision in the trachea so that the person with a blocked airway can breathe. Aspiration. So this is where I was talking about a patient can aspirate. You have pulmonary aspiration, and once again, I've got this picture here where you can see air in the lungs is supposed to go down the trachea, food is supposed to go down the esophagus. But sometimes that food can end up going down the trachea, which causes this pulmonary aspiration. It occurs when material from the oropharynx enters the lower respiratory tract. Aspiration mainly occurs in patients who have trouble clearing their lungs, such as those with diminished gag or cough reflex, and patients with decreased level of consciousness. So from here on out, what I will say is if you have a patient who just received surgery, always, always, always make sure to check their gag reflex before you let them drink anything, let them eat anything. And a lot of times you have to check that gag reflex before they can even go home. Because once again, what we're trying to avoid is pulmonary aspiration or even silent aspiration, where that food ends up falling into the lungs and they might notice it or they might not notice it. And another thing, and we'll talk about this when I show you the bronchus, but the shape of the bronchus or the bronchi actually does kind of play into which ones you'll see a little bit more often. So the left bronchus is curved, the right bronchus is more vertical. Because of the anatomy of it, aspiration often occurs in the right lung because of the straight route downward from the right bronchus, which when you see it, it'll make more sense when you see it visually about why that right side is just more likely to aspirate than the left. So from the trachea, it then branches into the right and left bronchi. Right primary bronchus is more vertical than the left. Aspirated objects most often lodge in that right primary bronchus or the right lung. Each bronchus branches into smaller tubes and eventually down to the bronchioles. Bronchioles end in clusters of microscopic alveolar sacs, the walls of which are made of alveoli. So that's when we talk about that alveoli, it's all the way down at the bottom of this inverted tree. Because if you really look at the lungs, it almost looks like an inverted tree. So there we've got the bronchiole, and then you've got your arteries here, which we'll talk more about our arteries in just a bit. And then you've got the alveolar sacs and then the alveoli here. And that's where you're getting that exchange between oxygen versus carbon dioxide. The function of your bronchi and bronchioles, air distribution, once again, alveoli is that exchange of gases between air and blood. Oxyhemoglobin is basically the combination of oxygen and the hemo portion of hemoglobin. Hemoglobin combines with oxygen in the lungs and then releases the oxygen to the peripheral tissues. It then collects carbon dioxide from the tissues and carries it back to the lungs to be excreted. So it's kind of like this transport system where I'm giving energy, giving oxygen to the tissues that I need to give it to, and then I'm taking away the carbon dioxide. Your pulse oximeter measures the percentage of hemoglobin saturated by oxygen, and the normal that you should have for that is 90 to 100% in a healthy adult. We'll talk more about this situation when we get into our COPD patients, but if you have a normal healthy adult, it should be that 90 to 100%. Now, like I said, this gas exchange of oxygen and carbon dioxide, it will occur in the respiratory bronchioles, alveolar ducts, and the alveoli. Those alveoli, just to kind of refresh you guys, are a thin-walled balloon-like structure that's surrounded by pulmonary catheter or capillaries. This unique structure basically enables transfer of both oxygen and carbon dioxide. Air enters the alveolus, the oxygen moves across the alveolar membrane to the blood. At the same time, carbon dioxide moves from the blood into the alveolus to be excreted by exhalation. Before we continue, I just kind of want to talk about this hormone called erythropoietin. It's secreted by the kidneys, and basically what its function is, it's responsible for the stimulation of red blood cell production, erythropoiesis, in the bone marrow. Now, you're probably asking yourself, well, why are we talking about red blood cells right now? The reason we are is because if you remember, your red blood cells are what carry your oxygen. So just kind of sticking with that idea is my red blood cells carry the oxygen. So with this erythropoietin, a lot of times what will happen is you'll have an increase of secretion by the kidneys in response to that low oxygen levels in the bloodstream. So what happens is my O2 sat goes down, my kidneys sense this, then they release erythropoietin, which tells my bone marrow to stimulate the production of red blood cells. So more red blood cells equals more availability of oxygen to bind and be carried by the tissue. Therefore, any condition that causes hypoxia, such as cardiac disease, lung disease, and change in atmospheric pressure, will stimulate erythropoietin secretion. Once again, hypoxia stimulates erythropoiesis. Chronic hypoxia stimulates kidneys to secrete erythropoietin. Erythropoietin stimulates the bone marrow to synthesize red blood cells. Chronic hypoxia causes constant synthesis of red blood cells. We're getting a lot more red blood cells, but we don't have oxygen to kind of be in that area. So this chronic hypoxia can cause things like clubbing of fingers. So that's where you'll see this normal angle of the nail bed opposed to this distorted angle of the nail bed. Cyanosis is that bluish discoloration of the skin and mucous membranes. This occurs when with hypoxia because of the excessive concentration of deoxygenated hemoglobin in the small blood vessels. So basically, in these very small blood vessels, I don't actually have as much oxygen, but my kidneys keep excreting erythropoietin, keeps trying to increase the red blood cells in hopes that it can carry oxygen. So what you'll see instead is this bluish discoloration of the skin, because I've got a lot of concentration of hemoglobin that does not have enough oxygen, if that makes sense. So the next thing we're going to move into is the lungs. The lungs, they're very large enough to fill the chest cavity. Apex is a narrow upper part of each lung. The base is the broad lower part of the lung. The pleura, which we'll talk about in just a second, it's moist, smooth, slippery membrane that lines the chest cavity. And then the function is breathing, so pulmonary ventilation. So diving a little bit deeper into this pulmonary anatomy, inspiration, lungs expand and increase their total volume. So when you say that you have inspiration, you're breathing in, expanding your volume. Expiration, lungs recoil based on the elasticity of the lungs. You release all that CO2. The change in lung volume during this process is described as compliance, which refers to the flexibility of the lungs. So when we say that our lungs have compliance, that they're compliant, that means that they have a good flexibility. Inflammatory mediators such as leukotrienes, which are secreted by the white blood cells, and histamine, which are secreted by the mast cells, stimulate bronchoconstriction. So what this basically means is when I've got a cold and I've released a lot of white blood cells to fight this pathogen, or I'm having an allergic reaction, I'm going to cause bronchoconstriction. So that's why when you have an allergic reaction, we want to hurry and fix that problem because it's an airway problem with that bronchoconstriction. So there's two basically primary functions when we talk about the lungs. There's ventilation and there's perfusion. Ventilation is this process of inspiration and expiration of air through the pulmonary airways. Now there can be different things that can affect ventilation. Something as simple as how deeply I can move my diaphragm can affect how I'm able to ventilate my air. For example, if I have a really weak diaphragm, then I can't take those really deep breaths, then with that one, I'm not able to get it air or oxygen down into the lower part of my alveoli. And this will come into more handy when we talk about a few things going onwards. Perfusion is the movement of blood through the pulmonary circulation, eventually providing oxygen to every part of the body. So perfusion is basically how we get the oxygen from the lungs to my foot, to my heart, to my brain. So a lot of times you'll hear me say things like, it's a loss of perfusion. That's why we care so much, is because it's a loss of perfusion. Because if you think back on it, oxygen helps gives us energy. Oxygen's the only thing aside from glucose our brain likes. So it's very important that we have a good sense of perfusion. So your lungs work very well together with this ventilation perfusion system. Where there's little ventilation, pulmonary artery vessels constrict, pulmonary hypertension. So if I'm not ventilating, like if I have an issue with my diaphragm where it's not allowing me to have those deep breaths, then my pulmonary artery vessels are going to constrict, cause pulmonary hypertension. Pulmonary artery vasoconstriction leads to redistribution of blood flow to better ventilate areas of the lung. So like I said, both of these kind of work with one another. With patients with chronic hypoxia can develop chronic pulmonary vasoconstriction, referred to as pulmonary hypertension, high blood pressure within the pulmonary artery system. So basically, in a nutshell, what I'm trying to say here is if for some reason I'm not able to get oxygen in, I'm not able to have those deep breaths for whatever reason, like somebody took too much morphine and they are in respiratory depression, so they're not able to breathe in deeply, then what's going to happen is the perfusion side of this is going to try to fix the problem by constricting, because they feel like if I constrict this area, then at least maybe I'll get some sort of perfusion. And that's where you get pulmonary hypertension. And that's where we're dealing with a breathing problem that we need to fix or correct. So we don't want our patients to be hypoxic, because hypoxia means I don't have enough oxygen to supply to perfuse everything that needs to be perfused. So when we have hypoxia, we need to ask ourselves, is this some sort of perfusion problem? Is this related to the fact that maybe my heart's not beating correctly? Or is this related to a ventilation problem? Is this some sort of reason where my patient was in a traumatic motor vehicle accident and they physically cannot open their alveoli? They physically cannot use that muscle anymore. So those are kind of the thought process you want to go into whenever you start seeing that your patient is hypoxic. What's the etiology behind this hypoxia? This here is just another alternative picture that you can look at as well. This picture here basically just shows that alveolus again, so you can kind of look at that and get a visual of what I was talking about. So moving towards the outside of the lung, we've got this pleural space. You've got the outer pleura and the inner pleura. And between the two pleura is the pleural space. Now, air or fluid should be within the pleural space. It should be a vacuum. Because it's a vacuum, the pleural space has negative intrathoracic pressure. So in this little area that's between the inner and outer pleural space, you should not have any air in this area or any fluid. If I develop air or fluid in this space here, then it's going to defeat the whole negative pressure, and my lungs aren't going to be able to fully expand. Then we have lung collapse. So with the pleural space, the lungs easily expand and retract during inhalation and exhalation within the empty pleural space. However, if air or fluid is contained within the pleural space, the positive pressure of the air or fluid pushes against the lung tissue and prevents its full expansion. Therefore, it is critical that the pleural space be completely void of air or fluid. And lungs are composed of the spongy, compressible tissue, collapse easily when pressure is placed against them by pleural fluid. So pleural fluid can be things like pleural effusion or air like pneumothorax. So like I said, we don't want any air in that in-between space. If we do, we lose the vacuum, our lungs basically shrivel up, and then I'm not getting full expansion, so I'm not getting good ventilation. If I don't get good ventilation, then I'm not going to get good. You can do the Dora the Explorer, pause for a second, and think about this. If I'm not getting good ventilation, what systematic problem am I going to have? Lack of perfusion. So that's why we get very concerned with things like pleural effusion or pneumothorax. So once again, we've got the trachea here that's splitting into the two different sides of the lungs. You've got two lobes on the left, upper and lower, and then three lobes on the right. And as you can see with this right side here, it's a very straight shot. So that's why a lot of times food, if it goes down the windpipe through here, a lot of times it'll end up in that right lung just because it's a little bit easier for it to fall into the right lung. Now that we've talked about the lungs and everything, I kind of want to talk to you again and just kind of talk about your CO2. Your stimulus to breathe comes from your CO2. So what happens is you'll have these very high levels of CO2, which is also called hypercapnia, and they stimulate the process of breathing, a CO2 that is greater than 45. Your central chemoreceptors, which are located in the medulla. So your medulla is part of your brain. It's the medulla oblongata, and it's basically uh, the part of your body that tells you to breathe, tells your heart to beat. It's everything that just happens naturally. I don't tell my medulla to do this, my medulla does it on its own. So basically, what happens is they will sense a change in carbon dioxide and blood pH and cause alterations in the rate and depth of respirations. Rate and depth increase in hypercapnia. An increase in CO2 or a decrease in pH stimulate the central chemoreceptors, resulting in increased rate of respirations. So hopefully it'll return to a normal pH. Because if you think about it, if I have respiratory acidosis, what kind of patient do I have? So you can pause the video for a second and think about this. So if I've got respiratory acidosis, I have a patient who's holding on to CO2. So they're not going to be breathing as much, correct? Because they're basically holding on to all that CO2. So that's where my body tells me, okay, I need to breathe slightly faster in order to blow off some of the CO2. So CO2 accumulating in the bloodstream stimulates the medulla and drives normal breathing. So for most normal people, what causes us to breathe is that CO2 accumulation. On the last slide, we talked about what happens with normal people. Now we're going to talk about what happens when somebody is in a chronic state of hypercapnia. So I've got a patient who's chronically holding on to their CO2. So this can be like my COPD patients. So for them, instead of CO2 being what tells them to breathe, it's now hypoxia. And this is a very, very important concept. So it's no longer CO2, it's hypoxia. With chronic CO2 accumulation, the respiratory center becomes insensitive to high CO2. Remember, our body has a way of just compensating for everything. So at this point, my body thinks that what's normal is to have high levels of CO2. So when these levels become high, my body basically ignores it. Therefore, low oxygen or hypoxia becomes the driving stimulus of respiration. Chemoreceptors sense low O2 levels, triggers the respiratory center. So this concept here is why when we get into COPD, our COPD patients are different on how we look at their O2 sat. Because up to this point, we've told you guys O2 sat has to always be from 90 to 100, correct? Our COPD patients are a little bit different, and it all comes back to this idea of low O2 or hypoxia is the driving force for these people who have chronic hypercapnia. Now, it's only for people who have chronic hypercapnia. So you just have to remember that this is only for people who are in a state where they have way too much CO2 on board. Another concept I want to talk to you guys is atelectasis. So this is a type of lung collapse where it's basically the collapse of the small number of alveoli resulting in reduced gas exchange. Now you can have a lot of etiology behind what causes this, but a lot of times what it's caused from is our post-operative patients. They receive sedation and surgery, they come back to us, they're not taking those big deep breaths, their alveoli close. And once these collapse, it's very, very hard to push them open because it's almost like if you've ever had one of those really, really old sponges, it's almost like they're those crusty sponges and we need to try to force them to work the way they used to. Now, with this is something that absolutely nurses can prevent, and it's something absolutely nurses deal with, so it's something absolutely you want to know how to handle. So with it, to treat atelectasis, the patient needs to cough and deep breathe. And when I'm talking about deep breathing, I'm talking about using your diaphragm. So this is diaphragmatic breathing. So what they can do is place a hand on the abdomen to create resistance and have them breathe very, very deeply in. So that way they can push all that air into their alveoli to force them open. Now, the other thing they can use is this incentive spirometer. Now, with him, if you look at the picture, you can kind of ask yourself, what is he doing wrong? And I'll let you pause for a second to look at it. What he's doing wrong is he's supposed to be breathing inwards, not outwards. But anyway, like I said, we want to prevent this whenever we can because getting atelectasis predisposes individuals to pneumonia. So we want to do what we can, reminding your patients. And what I would usually do is if they didn't like the incentive spirometer, I would also tell them to use something like a flutter valve. My idea behind it is I want people to try to deep breathe as much as they can because what I'm really aiming for is those lower alveoli. Because remember, I'm not supposed to have anything in that lower area, so I want to push it open with just oxygen. So here's our lovely incentive spirometer. This device encourages patients to inhale slowly and deeply to maximize lung inflation and alveoli expansion. So the whole idea behind it is I'm going to deep breathe. So I'm going to use that diaphragm breathing. Breathe, breathe very deeply, pull all that air in order to push the alveoli open. And it's used to prevent atelectasis. So you absolutely want to try to do it. And if you're in clinical and you don't know what to do, if you have a post-surgery patient, just ask them, do you know how to deep breathe? And teach them how to deep breathe. It's very, very helpful. Indications, post-surgery, pneumonia, atelectasis. Nursing care, positioning of the patient. You want them to be sitting up to fully expand their lungs and encourage use. If we don't make it sound like it's important, then they won't think it's important. Set realistic goals. Like honestly, if they couldn't make it to 4,000 before surgery, they're definitely not going to make it after. And record outcomes. You can make it almost like a game with them to try to encourage them to use this incentive spirometer. So these are just some of our key physical assessments. The first thing you do is inspection and assessment of respirations. Brandipenia, respiratory rate fewer than 12 minutes, 12 breaths per minute. Tachypnea, respiratory rate greater than 20 breaths per minute. Something that I suggest that you guys do is if you're not very comfortable with your vital signs, make a list of yourself of normal vital signs when you go to clinical and double check every one of your patients that you take vital signs on to see are they within normal range? Is there a reason why they're not in normal range? You can do palpation for tenderness, auscultation of adventitious breath sounds, symmetrical chest expansion. What you always want is to see symmetrical movement. As soon as things become asymmetrical and they're off, there's something wrong. Tactile firmitis, which I'll show you, as well as percussion. So tactile firmitis is the vibrations on the chest wall. It results of sound transmitting through the lung tissue. So you basically have them repeat a phrase over and over again, and you feel the intensity of firmitis by palpating the chest wall. So you go up and down and down and down. Some of the causes of decreased firmitis are things like excessive air in the lungs, increased thickness of the chest wall. Causes of increased rhinitis, lung consolidation, air in healthy lungs is replaced with something else. So this can be things like inflammatory, exudate, blood, pus, or cells. So whenever we see lung consolidation, usually, and I say usually because it's not always, it's something like pneumonia. So if you're hearing crackles, you're feeling increased firmitis, like let's just say that you're at home, your kid's sick, and all of a sudden you hear crackles, you're feeling the back, then you're probably going to want to take them to the doctor or urgent care because more than likely they probably developed some sort of pneumonia. So those are things that you can do to kind of help yourself to decide, do I need to go? Do I not need to go? It helps you kind of know what these assessment tools mean. Your abnormal breath sounds or your adventitious breath sounds. So these are extra lung sounds that superimposed over normal breathing sounds. And something that I find kind of interesting about your breath sounds is they almost have like a musical way of describing it. Because your heart sounds, they always kind of associate it with almost like a door opening and closing. Because if you look at the way those ones are described, it just very much sounds like a door opening and closing, opposed to wheezing where it has like a whistling sound. Ronchi, which is uh, a low pitched snore like sound. So it almost sounds like music. And if you think about it, what we're really listening to when we listen to our lung sounds is the movement of air. So for crackles, the reason I hear crackles is because I'm hearing water move through air. So it's almost like it sounds like as if I were to put a bunch of bubbles inside water. I can hear the swashing of water at the same time of hearing it move through the air, if that makes sense. And a lot of times when you'll see that is things like heart failure or pneumonia. Wheezes, on the other hand, has to do with constriction. So that's why it's a very high pitch, like very common in asthma. Because what you're really hearing is that whistling sound, where it's like a high pitched whistle. Then you've got rhonchi, which are a low pitched snore like sound that's over inflamed bronchial airways. And then finally, a friction rub, which is a scratchy sound. And if you think about it, that's an issue with my pleural surfaces. So I'm hearing that movement of inflammation moving against the pleural surfaces. We have two different types of pulmonary disease. You've got obstructive versus restrictive. And we'll talk about this more next week. I just kind of wanted to give you a preview for next week. Obstructive diseases, an increase in resistance to airflow from the trachea and larger bronchi. Restrictive, reduced expansion of lung tissue with decreased total lung capacity. So your lungs are stiff and non-compliant. And a lot of times these restrictive diseases are because I can't actually lift my diaphragm upwards, opposed to the obstructive disorders, which is having an issue with that airflow. So a lot of times with your obstructive disorders, you'll have air that's basically locked into the lungs that can't be expelled outwards, while with your restrictive disorders, it's I can't, for some reason, I can't actually fully expand my lungs due to something like a thoracic cage deformity. So the next thing we're going to talk about is your oxygen therapy. And what I will say about oxygen therapy is you will see this multiple times and you'll see this over and over again, whether it's in clinical, in this course, in the next course. I think I teach in all three med surg classes, and this oxygen therapy comes back in every single course. And the reason it comes back is because it's very important. It's part of our ABCs. So if you get kind of a good foundation of it, it'll make it much easier as you progress. So this is just a refresher of ABGs. ABGs reports the status of oxygenation and acid-base balance of the blood. pH is the amount of free hydrogen ions. O2 is the partial pressure of oxygen. CO2 is the partial pressure of carbon dioxide. Your bicarb is the concentration of bicarb in the arterial blood. Sorry, your HCO3. Your SaO2 is the percentage of blood bound to hemoglobin, and it can be obtained by an arterial puncture or through an arterial line. Now, before we do an ABG, you do have to do what's called a modified Allen test. So basically what I'm trying to see here is how good are my arteries? Can I use this artery to puncture to check? So what you do is you first turn the patient's palm to facing up, have the patient make a clenched fist, find the radial and ulnar pulse. So you're going to go ahead and find that. Apply pressure to the radial and ulnar artery at the same time with your thumb or fingertips. Let the patient open and close several times. Loosen pressure to the ulnar artery only. Evaluate the return of blood. Normal response, hand returns that normal color, appears flushed within less than 5 seconds. And we're basically doing this to see how well these arteries work before we puncture it, take the blood out. So these are just some helpful terms. FiO2 is the fraction of inspired air, defined as the percentage of concentration of oxygen that a person inhales. And at 21%, that's usually room air because you've got about 21% of oxygen just surrounding us. PCO2 is partial pressure of carbon dioxide. PO2 is partial pressure of oxygen. So this is our oxygen overview. Oxygen is this tasteless, colorless gas, and it accounts for 21% of the atmospheric air. And you have to ask yourself, why is that important? It's important because that means that any of us, our FiO2 at room air is 21%. So if somebody tells you, for whatever reason, they give you settings that, hey, my patient's at FiO2 21%, then you know, okay, they're on room air. It's given to maintain an SiO2 of 95 to 100% by using the lowest amount of oxygen without putting the patient at risk. So administration of oxygen at greater than 21% is to provide adequate transport of oxygen in the blood while decreasing the work of breathing and reducing the stress on the myocardium. So that's why you'll see sometimes if somebody comes in with a heart attack, they'll give them oxygen because I'm trying to make my heart not work so fast. And that comes back to, remember what I told you guys about erythropoietin, bone marrow, everything like that. Well, the kidneys are going to stimulate erythropoietin to release, cause the bone marrow to release red blood cells, but my heart still pumps it. So my heart's going to also increase. Our entire body works together, and you just need to start seeing how it all works together. Hypoxia is just that decrease in oxygen supply to tissues and cells and can also be caused by problems outside the respiratory system. Severe hypoxia can be life-threatening. Oxygen does have some dangers to it. You can have oxygen toxicity, and this may occur when too high a concentration of oxygen is administered for an extended period of time. Symptoms include things like substernal discomfort, paresthesia, dyspnea, restlessness, fatigue, general weakness, progressive respiratory difficulty, alveolar infiltrates on the x-ray. And the prevention of this is use the lowest effective concentration of oxygen. If you can titrate down, do it. Prevent a reverse atelectasis, so teaching them how to breathe with their diaphragm and allow lower oxygen percentages to be used. Oxygen-induced hypoventilation. So this comes back to that idea that I talked about before with our patients who have chronic hypercapnia. So this can develop in patients who have COPD and chronic hypoxia with hypercapnia. So that means I've got high levels of CO2. In severe COPD patients, increased levels of CO2 become chronic and chemoreceptors and respiratory centers become insensitive to high CO2 levels. The normal respiratory drive stimulus changes from PCO2 accumulation to low PO2. So basically, this means that I'm no longer having the drive when I have high levels of CO2. It's now my drive is for hypoxia. In severe COPD, hypoxia becomes that stimulus for breathing. So for them, administering high doses of oxygen can depress the patient's independent drive to breathe and can cause respiratory distress or respiratory arrest. So you can actually kill your patient by giving them too much oxygen. So I say this because in practice, and I'll talk about this more in class, I've seen this happen to people. You have to be careful when you give oxygen. This is why your assessments are so important, is because with a really, really bad patient who has severe COPD, giving them too much oxygen will make it so they are not breathing on their own. and eventually they'll go into respiratory arrest because they're going to need more and more supplements of oxygen. And they can enter respiratory acidosis. So you have to be very careful when you titrate oxygen, especially when this patient is requiring oxygen therapy. So for them, like a lot of times we go up by like two, depending on how your patient's doing. For them, like 1 to 2. For them, like if I'm moving a COPD patient up on oxygen, it's going to be very, very careful because I want to force them to breathe. Honestly, what would be more beneficial is to teach them how to do that deep breathing, how to force them, having them use their flutter valve to get them to breathe on their own. Oxygen is combustible, so make sure that you're placing things like no smoking, oxygen in use, know where the closest fire extinguishers are located, and educate patient on fire hazards. So a lot of our COPD patients are smokers, so you just have to let them know, please do not smoke around the oxygen. So I split up these between like low flow, advanced airways, everything like that. So that way you can reference these later as well. So we've got low flow oxygen delivery systems, which is your nasal cannula and your face masks. Low flows are usually the first ones we'll use. They're pretty easy to use, they're comfortable. The amount of oxygen delivered varies. Nasal cannula can be 1 to 6 liters. You can have a face mask, which can be simple, partial rebreather, or non-rebreather. And once again, the reason why I go through these is because you guys are going to be in clinical. So if somebody asks you, hey, go get a nasal cannula, I want you to at least be able to visualize this. So this is mostly just to kind of help you guys at this stage. We'll go into more detail in MedSearch too, but just being able to know, okay, if they're talking about a nasal cannula, this is what it looks like. It can deliver 1 to 6 liters of O2, has been proven to be ineffective after 6 liters. So if you're going into a patient's room, you see them on a nasal cannula and it's at 7, you probably want to go ahead and let their nurse know or let your clinical instructor know because it's not going to be it's not going to be helpful to them. They need something more than this nasal cannula. This is the initial therapy oxygen supplementation. Reservoir is in the upper airway, mostly in the nasopharynx. FiO2 is 24 to 44%, so it's very close to room air. Because remember, room air is that 21%, this one goes up to 24. Pros, non-invasive, very easy to tolerate, can be humidified. Cons, variable FiO2. This is where you walk into the patient's room and their nasal cannula is hanging off the side of the bed. At that point, it's not really helping them. It also dries the mucous membranes. That's why we want it to be humidified. And it's ineffective on mouth breathers. If you're a mouth breather, then the nasal cannula is not going to help you. Simple face mask covers the patient's nose and mouth. It delivers up to 40 to 60% for short-term use. Minimum is 5 liters per minute, and you want to ensure appropriate fit. So you want to make sure that it fully goes around the nose and the mouth. This is just a better picture of it. And then there's that metal piece that conforms the shape of the nose. Simple face mask, easy to use, more comfortable. Cons, flow rates of less than 5 liters per minute can result in rebreathing of CO2. So you need to be careful with that. Once again, if you're at clinical, you walk in, you see that they have this simple face mask, but their O2 is at like a 3 liters. Check on your patient first, make sure they're stable. If they're stable, you can ask your clinical instructor or ask the nurse you're working with and just let them know, hey, I noticed it was on this. Is it supposed to be on this? Device is poorly tolerated by patients who have anxiety or claustrophobia. Eating, drinking, and talking are impaired. So you have to think about, okay, they're not going to be able to eat with this mask on their face. And you want to use caution with patients who have high risk of aspiration, and moisture and pressure can collect under the mask and cause skin breakdown. So anytime you've got a mask on the patient's face, make sure that you're looking around their face, that they're not breaking down or we're causing any sort of skin issue. Partial rebreather mask covers the patient's nose and mouth, provides 60 to 75% with flow rate of 6 to 11 liters per minute. Patient rebreathes 1/3 exhaled tidal volume. So it kind of goes in this reservoir bag. So basically they breathe out, they get some of the oxygen back in, and then they've got some of the exhaled tidal volume down through there. That's another picture of it. So pros, mask has a reservoir bag attached with no valve, so the patient's actually able to rebreathe up to 1/3 of exhaled air together with room air. Cons, most of the cons again have to do with the mask fitting poorly. It's like poorly tolerated. They can't eat, they can't drink. You want to use very cautiously with patients who have that high risk of aspiration. FiO2 varies with patients' breathing pattern because once again, they're breathing back. So if they're not taking those deep breaths, then they may not be getting as much FiO2 as we want them to get. And complete deflation of the reservoir bag during inspiration causes CO2 buildup. So you want to make sure they're not completely deflating that. Non-rebreather or partial rebreather face mask covers the patient's nose and mouth, reservoir of oxygen in the bag. It can deliver FiO2 of 80 to 95%, must be at 10 to 15 liters. Like any mask, O2 must be higher than 5 to wash out CO2. Used primarily in emergencies and never meant for chronic use. So your duration for the non-rebreather is usually less than 4 hours. And then here are the little pictures of it as well. You can see those little one-way valves there. So your non-breathers can deliver a very high amount of O2 concentration, except for like if they're actually intubated or we're ambu bagging them, but they can give a very high concentration of that O2. Now, the thing with it is the one valve situated between the mask allows the patient to inhale that maximum O2, so it's very good for that 4 hour duration. You don't really want your patients to be on this for long term. This is mostly just to get them oxygen without having to go into an advanced airway. Some of your cons are, once again, these masks aren't very tolerated by anybody with anxiety or claustrophobia, as well as eating and drinking becomes very difficult, and you want to watch your patients who have high risk of aspiration or airway obstruction. So here are our high flow oxygen delivery systems. So as you can see, we've got the high flow nasal cannula, and as you can see, it's delivering more liters, like 30 liters per minute, opposed to before we could do up to 6 liters per minute. So this can do 30 to 60 liters per minute. It just means that it just has a higher flow to it, opposed to our low flow um, oxygen systems. This has a combination of heat and humidity, minimizes damages to the mucous membranes. Venturi mask covers the patient's nose and mouth. It has an FiO2 of 24 to 60% at rates of 4 to 10, depending on the different sizes of adapters. So this allows for specific amounts of air to mix with O2. Adapter is located between the bottom of the mask and O2 sources, and it pulls in proportional amount of the air with each liter flow of oxygen. This is just a picture of that Venturi mask. There she is with her Venturi mask. Now with this, you have to make sure the adapter is reading the same as the oxygen, or else you're not using it like appropriately. Like if your oxygen says something like 6, but your adapter says 4, then all she's going to receive is that 4. They both have to meet in order for them to get the intended amount of oxygen. Pros delivers the most precise oxygen concentration. Humidification is not required, and it's best suited for patients who have chronic lung disease. Cons, it can be very expensive, and once again, with any mask, we run that risk of difficulty eating, talking, aspiration. Aerosol masks, so these are face tents that fit loosely around the face. Tracheostomy collar is a small mask that covers a surgically created opening in the trachea. They can deliver 24 to 100% FiO2 at flow rates of at least 10 and provide high humidification. And there's both of your masks there. So this is good for patients who have facial traumas, or maybe they just can't tolerate the mask because it's not as claustrophobic as the other ones. Cons, high humidification, which requires frequent monitoring. Because remember, if we get the skin very moist, we get concerned about possible skin breakdown. T-piece delivers desired FiO2 to clients with tracheostomies, laryngectomies, or ET tubes. It can deliver FiO2 of 24 to 100% at rates of at least 10 liters and above. Aerosol should appear on exhalation side. And there's that picture of that T-piece. It can be used with patients with those very specific things like your tracheostomies, anything of that nature. Cons, high humidification requires bag valve mask, also called an ambu bag, for manual resuscitation. Will initiate a breath for the patient. Chest should noticeably rise, critical for hypoventilating patients, and can deliver high flow oxygen. And this is what that looks like, that ambu bag. So if somebody, like, for some reason, if one of your patient codes and they ask you to grab an ambu bag, this is what it looks like. These are your non-invasive positive pressure ventilations. So what I will say about these positive pressure is sometimes it may not necessarily be that I need oxygen, but I need pressure, because remember, it's the alveoli. I need something to force the alveoli to open. So continuous positive airway pressure, which we'll talk about more when we get into sleep apnea, it provides positive pressure using a leak-proof mask with non-invasive positive pressure ventilation device. Device is used to keep the airways open throughout respiratory cycle and improve gas exchange in the alveoli. Most effective treatment for sleep apnea because the positive pressure acts as a splint to keep the upper airway and trachea opening during sleep. So basically what it is it's pushing pressure through to keep the trachea open so it doesn't collapse on them. Okay, so the next thing we're going to talk about is our advanced airway. Okay, so tracheostomy is a surgical incision into the trachea to create an airway to maintain gas exchange. Tracheostomia is, or stoma, is a stoma opening that results from the tracheotomy, and it can be temporary or permanent. And you really need to understand that not everybody who gets a trach keeps it forever. So some of these patients really are on their way to recovery. So you want to treat them with as much independence as we can. So these patients can eat. Some of them that may have a trach, they can still eat and everything. You just have to be careful to watch them that it's not going down the wrong pipe. This picture here just shows that tracheostomy. So just as like an overview, tracheostomy is a sterile surgical incision into the trachea through the skin and muscles for establishing an airway. Now, this can be a scheduled procedure or this can be due to an emergency. So it can be something like emergent where they have facial trauma or thyroidectomy and they have to hurry and get this airway. Or it can be something where my patient was on an ET tube for the last 2 weeks. They still need help breathing, but we can't keep the tube in them. Let's go ahead and give them a trach instead. And like I said before, this can either be permanent or temporary. So some of your indications can be patient can't be intubated and an airway must be established. That's very rare with it. Or the patient cannot be weaned from the ventilator and are given a tracheostomy. So general timeline is 7 to 10 days as the trachea becomes damaged and long-term endotrachea intubation. Cuff pressure is usually between 20 to 25. Honestly, I would talk to a respiratory therapist about that as well because I've seen in the literature those numbers slightly vary. So double check with it, but the last one I saw, cuff pressure between 20 to 25. You want to make sure you clean the stoma. Do not place gauze under the trach tube as debris can be inhaled in the lung. Watch for secretions and suction only when indicated. Always listen to your lung sounds. I can't stress this enough. When it comes to suctioning, like on your computer screen, they'll usually tell you if you're working with a trach, it will automatically tell you, I think it's like every 2 hours, usually it tells you need to suction your patient. I always do it based off assessment and I talk to my respiratory therapist because if they just suction my patient, I don't want to go in there and over suction them as well. Ensure tracheostomy tube is secure, so making sure you're looking at those tubes. And this is just several pictures of them labeled. So providing tracheostomy care, you want to assess, secure tracheostomy tubes in place, and prevent accidental decanalization. So this is the tracheostomy care. You want to first assemble equipment, suction the tracheostomy tube, remove your old dressing and excessive secretions, set up your sterile field, remove and clean the inner cannula, clean the stoma, change the tracheostomy ties if they are soiled, secure new ties in place before removing the soiled ties to prevent accidental decanalization. And I cannot stress this enough. Make sure you have them very secure before you remove the soiled ones. Because honestly, if you've got a patient who coughs a lot, they can accidentally cause that decanalization. And at the very end, you want to document everything. Tracheostomy suctioning, which you should be doing in lab. So make sure that you absolutely know how to do this. So assemble the necessary equipment, also take the lungs and check the heart rate. Prepare by turning on the suction. Hyperoxygenate the patient, don sterile gloves, guide the catheter into the tracheostomy tube using a sterile gloved hand. Be careful with suctioning. Let's not take our patient's breath away, aka do not suction while inserting the catheter. That is a very, very big no-no. And if you think about it, if I'm inserting the catheter and I'm also suctioning at the same time, is my patient able to hold on to that breath? I'm basically just removing all that hyperoxygenation that I just gave them. And this is just like a helpful little picture of the tracheostomy suctioning. These are some more essentials. Must be humidified because once again, it bypasses the pharynx. So I don't have anything that's humidifying it. Ensure patient has some way of communicating. You want the call light within reach, and they may not be able to scream. Now, some of these with a more chronic trach are able to use assisted devices to speak, but don't assume they can talk. Frequent assessment of lungs. They are at risk for aspirating. We may be trying to wean them off of the trach. So remember, like, these patients can chronically have a trach. So you might have somebody who has a tracheostomy that, for example, might be eating or something. So they can be fed by your assistive personnel. Assistive personnel all of a sudden comes up to you and says, hey, they start coughing a lot. What are you going to do? Listen to their lungs. That's what you want to do first. Listen to their lungs and assess if any of that went to the wrong area. Your tracheostomy care and delegation. The first thing you want to do is assess your patient for stable versus unstable. If unstable, you got to be the one to perform the care. It doesn't matter what care it is, either you or the respiratory therapist has to perform the care. If stable, ask yourself, what is the task? Is my person allowed to do this? And remember, some of these patients may have a trach chronically, so it is okay to delegate. Once again, remember the licensure of who you are delegating to. Suctioning, trach care, vent settings, humidification, LPN if stable, your assisted personnel, never. You never, ever, ever, ever allow any of these things to be delegated to your assisted personnel. Oral care, such as applying lip balm, mouth applicators, if stable, LPN, RN, AP, pretty much anybody can do this portion. If unstable, you got to be the one to do oral care. And don't assume the patient is unstable unless, like if you're reading these questions or if you're going through NCLEX and doing NCLEX prep, don't assume the patient is unstable unless it specifies that your patient is unstable. Reminding patients to deep breathe and cough. If stable, everyone. If unstable, your job. Note, respiratory therapy can do all of the above. They went to school for this. So these are just some tracheostomy complications. The first one is subcutaneous emphysema, which basically what happens is you'll have gas or air accumulation that seeps under the skin. So this happens sometimes with newer trachs. So we'll talk about this more in depth in MedSearch 2. I just wanted you to be kind of aware of these complications. You can also have tracheointimate artery fistula, which is basically you have an abnormal connection between this artery here as well as your trachea. And basically what happens is you walk into the room with a new trach and the pulsation of the tracheostomy tube is synchronized with the heartbeat. This can be very, very life-threatening, which is why I tell you guys about this because I don't know where you guys are going for clinical. So if all of a sudden you go in and you see somebody's trach is beating at the same rate as their heart rate, this is a life-threatening emergency. So you want to stay with the patient and alert provider immediately. So if you see this happening, then hit the call light and say, I need a nurse in here, or get help immediately. Other complications are things like tube obstruction, which can be caused by blood or mucus, or tube dislodgement and accidental decanalization. So tube comes out accidentally. Other ones can be pneumothorax, bleeding, infection. These are all complications that can happen after a tracheostomy. This last video here basically comes from a respiratory therapist, and what he does is he explains all the different parts of a trach. It's very helpful, especially if trachs kind of freak you out right now, so it kind of demystifies trachs. So it is a good watch if you want to watch it. Like always, thank you, and I look forward to seeing you all again.